of the middle thoracic standing behind the patient. So we're going to turn around, and I'm going to first have the patient bend his head, let your head dangling, relax the arm completely, fix the pelvis, fix the hip, lock the knee, feet at shoulder width, and no heels on the shoes. I'm going to adopt the position of fencer stance, passively cross the patient's arm, stuck my sternum right at the level that I want to treat, gently tilt the patient toward me, lower myself, segmentally extend the patient, ask the patient to breathe in, breathe out, and trust with my feet. So the cervical arc of tension is created by bending the patient's head. Let your head dangle forward, beautiful. And we get that cervical arc of tension going up to the higher thoracic. The caudal arc of tension is created by the lumbar lordosis, and the lumbar lordosis itself induced by a contraction of the muscle psoas that inserts on the top of the femoral head. So basically, the curvature of the lumbar lordosis is going to create your caudal arc of tension. Now the transverse arc of tension, would you mind to turn please? Face the wall, okay. The transverse arc of tension is going to be created passively by crossing of the arm. And here we're going to have an increase in the caudal arc of tension. The segmental extension, relax the turn around, is created by a light retropulsion of the patient's shoulder and a plie push of the sternum. So we're going to go like that.
Pull the shoulder backward and push with my sternum, and that would be the segmental extension. As a reminder, in the standing thoracic adjustment, the arc of tension model details the creation of a cephalad vertebral block that you move over a caudal vertebral block through a lifting thrust. Relaxation between those two vertebral blocks focuses the distractive force at the interblock level. By creating a vertebral block, you eliminate the natural shock absorption of the spine. Vertebral blocks are built by creating arc of tension via the ligaments and muscular tensioning. Neck flexion is used to increase the cephalad arc of tension. As the patient bends his head, the posterior longitudinal ligament between the spinous process is suddenly tensed. This tension tightens the cervical vertebrae together, creating a rigid vertebral block. This vertebral block prevents the dispersion of the distractive force through the cervical spine. In other words, the cervical segment being rigid does not dampen the lifting thrust. Passive internal rotation of the patient's arms tenses the interscapular muscles, specifically the rhomboid major and minor. This muscular stretch creates an horizontal arc of tension. It is essential for this stretch to be passive, as active motion by the patient reduces the amplitude of motion, which leads to a weaker arc of tension. This transverse arc of tension will anchor the cephalad block to lift it off the caudal block. Remember, you need to cross the patient's arm for him and not let him do it himself. Maintaining the lumbar lordosis during the lift ensures an optimal caudal arc of tension. As the patient is lifted off the ground, the heavier pelvis and leg pull on the lumbar spine, tending to flatten it. If the lumbar spine flattens, it absorbs most of the cephalad traction, dampening the effect at the thoracolumbar junction. Maintaining lumbar lordosis during the lift ensures an optimal caudal arc of tension. One way to maintain this arc of tension during the lift is to increase it prior to the lift. Segmental extension performed just before the lift is the key component in the increase of the lumbar lordosis. Several muscles, when contracted, help maintain the lumbar curvature. The psoas muscle inserted on the anterior lumbar vertebral body increase the curvature upon contraction. Similarly, the erector spinae muscles contribute to this effect. The straight leg maintains a psoas pull, preserving the lumbar lordosis, and using a pillow case can increase even more this lordosis. High heels on the patient's shoes bring slacks in the erector spinae muscle, leading to a flattening of the lumbar lordosis when the body is left off the ground. So no heel on the patient's shoes prior to perform the technique. Using a block to dorsiflex the patient's forefoot can facilitate the technique, and it is a facilitating technique. Breathing out eliminates the shock-absorbing air cushion created by the air volume in the lungs, decreasing the compressive aspect of the technique and diminishing part of the spring effect on the ribs. Having air in your lung shock absorb any type of compression on the thorax. The practical interest. The technique can be performed anywhere. There is no requirement for any kind of equipment. And mostly and very interesting fact is the technique is more distractive than compressive, making it very interesting for specific conditions. The clinical interest of the technique or chiropractic nosology. What kind of condition will be mostly helped with this technique? Intercostal neuritis is one. The ribs interspace is opened during a heel lift adjustment, while in a prone adjustment, the rib interspace is closed. So this makes this technique much more interesting than a prone technique in the case of an intercostal neuritis. Painful scoliosis. The spine being distracted presents less risk of a locking mechanism such as it is encountered in a prone adjustment. Emphysema. The technique can be converted to a more distractive approach than a compressive approach, and this circumvents the poor chest expansion encountered in emphysema, making it very uncomfortable to the patient when this one is being treated prone. Age compression fracture. The segmental extension performed during positioning takes away the pressure on the anterior vertebral plateau, making it very comfortable to the patient. There are some limitations to the use of this technique. Patient and doctor must be within 20% of the same height. Otherwise, it's very uncomfortable for either the doctor or the patient. Female doctor requires a breast protection, it's obvious, and patients with emphysema or difficulties emptying their lungs are not the ideal candidates for that technique. Other limitations include patients who have smoked within an hour prior to the adjustment. they have an increased lung volume, which is detrimental to this technique. And also, without forgetting, patient needs to remove their shoes if they have heels. What are the risks associated with this technique? Generally, it's a very safe technique, but shoulder pain in internal rotation is a contraindication, requiring a technique modification that we will see later on. There is also the problem with hyperextension of the thoracolumbar junction that may create a thoracolumbar junction jamming, resulting in an instant, temporary, sharp pain. To avoid this, keep the patient's feet on the ground during the lifting thrust. Facilitation and modification to adapt this technique. There is a post-neural facilitation of the transverse arc of tension.
Let me show you here. I'm going to ask the patient, first I passively cross the patient's arm, and he has normally his head bent, okay? And I'm going to ask him, try to open your arm, correct? Push, open, 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 relax, and nice stretching. Open, open, relax, and nice stretching. And more I do that, more amplitude in the internal rotation of the shoulder I have. Open, 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 relax, and nice stretching. And then he's ready to be treated. So that's post-neural facilitation, and it's a very, very good facilitating process to treat the mid-thoracic.
There is also the muscular fatigue given with wall push-up to the patient.
There is another type of workout that we can have the patient perform to relax the shoulder girdle muscle and allow us to have a better result during the adjustment. And I'm going to ask the patient to go against the wall. You go against the wall. You're going to put both hands on the wall. Back up of the wall a little bit. Beautiful. Straighten your arm. So back up a little bit more. Beautiful. And now you're going to come against the wall. Drop your head forward. Come close to the wall and push back against my resistance. Push, 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 push. Good. Push, 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 push. Good. Relax. Again. Push, push, push. And that's what this movement will do, basically. We will create a motion in an area that we want to treat, and it will facilitate the outcome of the adjustment with more frequently an audible release.
There's also the possibility to use a towel wrapped around the patient's arm if your arms, as a doctor, are short and do not reach the patient's elbow. And finally, we can use a cushion to increase the patient's lumbar lordosis and increasing in the same time the lower arc of tension. To memorize this technique, you do not need a patient. You can perform it by yourself, solo, without a patient. Let's do it together and you will learn faster.
Treatment of the mid-thoracic, patient standing, doctor standing, back to the patient. Position of the patient. Patient will be standing square stance, his head forward, his arm dangling, pelvis will be locked, hip will be locked, knee will be locked, feet will be at shoulder width apart, and there will be no heels on the patient's shoes. Action of the doctor. Fencer stance. First, bend the patient's head. Cross one arm passively, the other arm passively. Stuck your sternum against the mid-thoracic. Slightly lower yourself. Pull on the arm and segmentally extend the patient. Give breathing instruction. Take the slack out. Thrust from the feet.